so happy to have Dr. Shivani Bhatt with us today. She's one of our advanced imaging cardiologists. She's presenting primary care considerations in children with congenital heart disease. This is for CME credit, so I will be sending a follow-up email on how to claim your CME credits. You will have 90 days to do so after this presentation. And again, if you have any questions regarding that, you can certainly message me during this presentation privately on the chat feature, or you can email me afterwards. We will have a Q&A session at the end of this presentation with Dr. Bhatt, and we invite you and encourage you to participate in that as well. So thank you so much for joining us today, and we will get started.
Okay. Good afternoon, everyone, and thank you so much for tuning in to our Lunch and Learn today. As Melissa mentioned, my name is Shivani Bhatt, and I am a cardiologist at Children's National, and today I will be talking about primary care considerations in children with congenital heart disease. So today, the objectives of this talk include reviewing aspects of primary care that may be affected by the presence of a congenital heart defect and perioperative concerns. I will discuss special considerations regarding nutrition, growth, and development in patients with congenital heart disease. I will also discuss recommendations related to physical activity, immunizations, and dental care in this population, and I have no relevant disclosures. Congenital heart disease occurs in approximately 1% of live births, or approximately 32,000 to 35,000 children are born with congenital heart disease per year nationally, making congenital heart defects the most commonly occurring birth defect. There have been significant improvements in diagnosis, medical management, and surgical treatment of CHD, and this has resulted in improved survival in patients with congenital heart disease. Therefore, there are now increased numbers of children as well as adults with CHD living in the community. These children not only require subspecialty care, but require comprehensive primary health care to ensure the best long-term health and outcomes. And there are many aspects of health maintenance that may be affected by the presence of a congenital heart defect. There are special considerations in these children related to growth and nutrition, development, immunizations, physical activity, dental care, among others, which I will touch on today. There is a broad spectrum of congenital heart defects that can occur alone and in combination and range in severity from hemodynamically insignificant to extremely complex and life-threatening. Basic classification of congenital heart disease, as shown here, can be made by direction of blood flow through intracardiac shunts. For example, lesions that cause blood to flow left to right through shunts are called acyanotic lesions. An example of an acyanotic lesion is a ventricular septal defect. When blood flow is shunted across the VSD, it is normally in the direction from left ventricle to right ventricle. Thus, oxygenated blood returning from the lungs to the left ventricle shunts to the right ventricle, where it mixes with deoxygenated blood returning from the body. In most cases of a VSD, the child's oxygen saturations are normal. We know children with large left to right shunts may have increased pulmonary blood flow and therefore may develop symptoms of pulmonary overcirculation, or also known as congestive heart failure. They may require medical management for pulmonary congestion. Children with right to left shunts have cyanotic lesions. Tetralogy of Fallot, as well as the others listed here, are cyanotic congenital heart defects. As you know, tetralogy of Fallot involves a narrow right ventricular outflow tract, a VSD, and an overriding aorta. And depending on the degree of right ventricular outflow tract obstruction, the child will have varying degrees of cyanosis and decreased oxygen saturations. Anatomic classification of congenital heart disease includes patients with primarily valvular disease, such as bicuspid aortic valve, Ebstein's anomaly, and mitral valve disorders. The symptoms and treatment are often dependent on the valve function, specifically the degree of stenosis or regurgitation. Patients with complex single ventricle type congenital heart disease present the greatest challenge to cardiologists and primary health care providers, as these types of defects are among the most serious types of congenital heart disease. For example, a child with single ventricle physiology, such as hypoplastic left heart syndrome, will require a staged surgical palliative approach involving up to 3 open heart surgeries to redirect blood flow. They will require close monitoring, as many will be dependent on a surgical shunt for pulmonary blood flow in the neonatal period. There are types of congenital heart disease that are primarily extracardiac, including coarctation of the aorta, vascular ring, and aortic dilatation, as well as branch pulmonary artery stenosis. In general, children with unrepaired congenital heart disease and residual defects after cardiac surgery may be at increased risk of mortality and morbidity because of potential for underlying cardiopulmonary compromise. The primary care provider plays a critical role in ensuring the health and well-being of patients with congenital heart disease. As I mentioned, congenital heart defects can play a role in many aspects of healthcare maintenance. These issues will be unique to every patient, given the vast spectrum of congenital heart disease as I described. However, today we'll attempt to give a broad overview of the primary care considerations related to growth, nutrition, feeding, neurodevelopment, immunizations, infectious considerations, as well as physical activity. Growth can be affected in the setting of congenital heart disease to varying degrees. Poor growth and failure to thrive are well-documented sequelae of hemodynamically significant congenital heart disease. The causes are likely multifactorial and may include increased metabolic demand and increased energy requirement. There may be inadequate caloric intake to keep up with these demands. Infants with unrepaired CHD often experience poor nutritional status as a result of difficulty feeding. They may take longer to feed due to symptoms such as tachypnea or fatigue with feeding, or have poor appetite and refuse to eat. Other associated congenital anomalies may also affect growth. Certain genetic syndromes may lead to difficulty feeding, such as trisomy 21 and DeGeorge syndrome. Oral aversion may develop in some infants in whom oral feeding was delayed because of hemodynamic compromise after birth. There is significant energy requirement with activity in children with congenital heart disease before repair. Therefore, careful screening of the nutritional status of patients with CHD is an important part of routine primary care. Infants with unrepaired congenital heart disease often have a normal birth weight but have decreased growth rate. The clinical picture of failure to thrive in a child with CHD may include poor weight gain, decreased linear growth, and some slowing of cranial growth. Children in congestive heart failure, such as those with hemodynamically significant shunt lesions, like VSDs, may have near normal linear growth but slower weight gain. Children with cyanotic heart lesions may have a more uniform slowing of weight and height. Close monitoring of the growth of patients with CHD, particularly those with failure to thrive, is necessary. It is important to track growth parameters such as weight, height, head circumference, and average caloric intake. Average weight gain goals for healthy infants can be kept in mind when monitoring infants with unrepaired CHD. Newborns up to 3 months of age should gain on average approximately 30 grams per day. Infants 3 to 6 months of age gain approximately 20 grams per day, and older infants ages 6 months to 1 year should gain about 12 to 15 grams per day. In certain cases, continued growth along the patient's own curve, even if low, may be acceptable for some period of time. However, flattening of the growth curve is often one indication to intervene. A red flag should be raised for children who are less than 5% on their growth chart, whose weight becomes substantially disproportionate to their height, or for whom the rate of weight gain is less than 25% as expected. A quick calculation of the patient's expected weight gain can let the provider know if the patient is consuming adequate calories with their current feeding regimen. It is important to recognize growth failure early on, not only to ensure optimal growth and development, but also to determine the need for initiation of nutritional intervention, further medical management, such as initiation of medications, or earlier surgical intervention. If there is evidence of poor growth in unrepaired CHD, there may be a role for increasing caloric intake to optimize growth and nutritional status. In addition, the cardiologist may consider initiating medications to manage symptoms of pulmonary overcirculation, such as diuretics. And in certain cases, earlier surgical intervention or repair may be indicated. Providing adequate calories for growth can become a challenge for these children and their families. Assessment of the volume and frequency of feeding and estimating caloric intake is important prior to nutritional intervention. Nutritional intervention may include increasing the volume of feeds as tolerated, carefully increasing the caloric density of formula or breast milk anywhere from 22 to 30 kilocalories per ounce, and giving smaller, more frequent feedings to prevent tiring with feeding. For bottle-fed infants, formula can be fortified anywhere from 22 to 30 kilocalories per ounce to provide 120 to 150 kilocalories per kilo per day. Parents should be advised to follow mixing directions carefully. Nutrition consultation can be considered as well to formulate a feeding plan in certain cases. Bottle feeding is frequently recommended for infants with congenital heart disease who are having difficulty with feeding and weight gain, because it may allow the infant's intake to be more accurately measured. However, the severity of the cardiac defect does not predict the infant's ability to breastfeed. Therefore, breastfeed should not be automatically eliminated as an option for a child with congenital heart disease, as long as the child is gaining weight. In fact, breastfeeding should be encouraged as long as the infant is gaining weight. If the child needs additional calories, the mother can pump breast milk and fortify it with formula and bottle feed the child during some feedings. Reserving breastfeeding for the nighttime or early morning feeds provides continued mother-infant contact and bonding. For those infants who fail to gain weight despite being fed fortified formula or breast milk, enteral feedings may be considered through nasogastric or gastric tubes. Inpatient admission for a nutrition consult, initiation of feeds, as well as family teaching would be required. Depending on the infant's needs, continuous or bolus feeding can be started with the use of fortified formula or breast milk. The practice of sending high-risk infants home with nasogastric tube is variable among different centers because there is a risk of aspiration if the tube is dislodged or incorrectly placed. The risk of enteral feeding also includes possible formula contamination, aspiration of formula, overfeeding, if the pump malfunctions, tube dislodgement, among others. Therefore, families need to learn to change the tube, care for the tube, and respond to emergencies prior to discharge. In some centers, insertion of gastric tubes in high-risk patients may be considered before they are sent home. Children with congenital heart disease are at increased risk for issues with neurodevelopment. The prevalence and severity of developmental issues increases with the complexity of CHD and is associated with several genetic syndromes. Children with more complex CHD have a significantly increased risk for developmental disorder in the areas of intelligence, academic achievement, language, visual, construction, and executive functioning, fine and gross motor skills, and psychosocial maladjustment. The cause for developmental issues in congenital heart disease is likely multifactorial, and we are learning more about this as time goes on. Can include changes due to chronic disease, genetic causes, being placed on cardiopulmonary bypass, and there's now some evidence that neurologic changes that can affect development may begin before birth. This figure from the American Heart Association scientific statement on neurodevelopment in children with congenital heart disease depicts the prevalence of neurodevelopmental impairment in the population with CHD. Children with milder forms of CHD, such as atrial septal defect or ventricular septal defect, isolated semilunar valve disease, have a low incidence of developmental issues. Increasingly complex forms of moderate biventricular CHD, for example, coarctation of the aorta, complex semilunar valve disease, atrioventricular septal defect, VSD with comorbidities, tetralogy of Fallot, total anomalous pulmonary venous connection, are associated with increasing numbers of children with developmental disorders. In those patients with severe biventricular or palliated single ventricle congenital heart disease, for example, transposition of the great arteries, truncus arteriosus, interrupted aortic arch, tetralogy of Fallot with pulmonary atresia and major aortopulmonary collaterals, pulmonary atresia with intact ventricular septum, hypoplastic left heart syndrome, and tricuspid atresia, only the minority of children are completely normal in all respects. Congenital heart disease associated with genetic disorders or syndromes, for example, Down syndrome, 22q11 deletion, Noonan syndrome, Williams syndrome, and multiple congenital anomalies such as Charge syndrome are nearly always associated with a developmental delay. There are certain categories of pediatric patients with congenital heart disease who are higher risk for developmental disorders or disabilities. Specific high-risk groups were identified in the AHA scientific statement entitled Neurodevelopmental Outcomes in Children with Congenital Heart Disease, Evaluation and Management, in order to facilitate early evaluation, diagnosis, and intervention that may improve developmental outcome. The high-risk groups include neonates or infants requiring open heart surgery, children with cyanotic heart lesions not requiring open heart surgery during the neonatal infant period, for example, certain types of tetralogy of Fallot, as well as any combination of CHD and certain comorbidities, including prematurity, recognized developmental delay in infancy, genetic abnormality associated with developmental delay, history of mechanical support, such as ECMO or VAD, heart transplantation, cardiopulmonary resuscitation at any point, prolonged hospitalization, as well as postoperative seizures related to cardiac surgery, and significant abnormalities noted on neuroimaging or microcephaly. The 2006 AAP algorithm for developmental surveillance and screening highlights the importance of early diagnosis and management of developmental disorders and identified the medical home, which is generally considered the primary care setting, as the ideal place to perform regular surveillance and screening. Therefore, developmental issues in infants and children with CHD is a potential problem that can be addressed during primary care visits. To achieve the best care for this population, the AHA scientific statement recommends a coordinated care model is needed. Individualized plans should be developed through a collaborative approach, which should include a primary care provider and or subspecialists, such as a pediatric cardiologist, pediatric neurologist, developmental pediatrician, psychologist, and other pediatric developmental specialists, as well as the child and the family, to coordinate and implement a specific care plan as an organized team. Congenital heart disease requires heightened surveillance for developmental issues, and this can be performed in all patients with CHD, including systematic risk stratification for early identification of developmental problems. Surveillance involves the following critical elements. Providers should elicit and attend to parental concerns. Responses obtained through posing questions to parents or caregivers regarding their concerns about their child's development can be a powerful predictor of developmental problems. Parental concerns regarding development should be evaluated and triaged appropriately because these discussions may provide important information in addition to the data obtained by formal developmental screening. It is also important to maintain a developmental history for tracking the progress of children receiving therapies for known developmental concerns and for monitoring of latent problems using appropriate developmental milestones for each child. Primary providers should also interact with early intervention programs, schools, early childhood education, child care programs, and other community agencies, if possible, to help ensure that the special needs of the child and family are addressed. Observation of a child's development by the primary provider during office visits is also an important part of surveillance. Identifying the presence of a specific risk factor and or protective factors is also a part of surveillance. Risk factors can be identified through past medical history, perioperative course, presence of a known genetic or neurologic disorder. In addition, other non-medical risk factors may include parental stress levels, parental guilt relative to causation of a birth defect, attachment issues, fear of the child dying, and stress related to surgeries. Risk factors may be balanced by protective factors in the environment or family, such as socioeconomic status. Higher socioeconomic status may be an important predictor, potentially having a greater impact than many clinical or operative factors on neurodevelopmental outcomes. Socioeconomic status has been shown to have a positive correlation with IQ and academic achievement in pediatric patients with CHD. The provider should either screen the child for confirmation of the developmental delay using standardized developmental screening tools or directly refer the child for formal developmental evaluation when a developmental concern is identified through surveillance. The decision between screening and evaluation is made at the discretion of the medical provider, who can balance the individual needs of the child with the specific resources locally available. Formal developmental evaluation is composed of detailed testing that typically requires specially trained medical or developmental professionals and standardized instruments of greater length and depth. The aim of evaluation is for identification of the specific developmental disorder affecting the child and his or her appropriate management. If the significant development delay is recognized by evaluation, a child can be referred for early intervention services, including special early childhood education and developmental therapies such as motor or speech therapies as appropriate. screening tool should be administered to children with CHD who are undergoing age-recommended developmental screening, as well as children with congenital heart disease in whom developmental concerns are identified through surveillance. The 2006 AAP policy statement and the 2008 Bright Futures Guidelines provide a formal algorithm on developmental surveillance and screening in the general population. Formal, standardized developmental screening tools are recommended to be administered at the 9, 18, 30, and 48-month visits. Autism-specific screening is recommended at 18 to 24 months of age. Both of these AAP developmental screening statements recommend specific screening tools. These tests have been shown to be reliable, valid, sensitive, and specific for the identification of developmental delay and typically only require a brief time for completion and scoring. Current screening tests include parental questionnaires about the child's development and patient screening tests that involve directly testing a patient by the medical professional. School-age children with a history of cardiac surgery for complex heart defects in the newborn period have been found to be at increased risk for inattention and hyperactivity, with many requiring remedial school services. Therefore, early recognition and referral for testing and treatment for attention deficit and hyperactivity should be initiated during primary care visits. This flowchart summarizes the process for developmental evaluation of the patient with congenital heart disease as recommended by the American Heart Association and AAP. If the child has congenital heart disease, the first step is risk stratification. If the patient meets the high-risk category, as outlined here in this chart, formal medical and developmental evaluation and early intervention referral should be considered, with plan for supportive therapies as indicated. This formal evaluation should be performed after initial risk stratification and periodically reevaluated at 12, 24 months, 3 to 5 years, and 11 to 12 years. If the patient does not meet criteria for high-risk category of CHD, and if the patient is 9, 18, 24, 30, or 48 months old, they should be administered an appropriate developmental screening tool. If the screening is positive, they should be referred for formal medical and developmental evaluation and early intervention. If there is a negative screen, they can follow up with reevaluation at the next visit. If the patient does not fit the age criteria mentioned, the pediatrician should perform surveillance, as I discussed earlier. If there are developmental concerns that arise from surveillance, a screening tool can be administered, and further management can be dependent on the result of the screening. To summarize, the recommendations from the AHA neurodevelopmental outcome in children with congenital heart disease include: the medical home model of care may be effective and beneficial in the management of patients with chronic conditions such as congenital heart disease. Existing AAP guidelines for surveillance, screening, evaluation, and intervention should be adhered to, with the following additions for patients with congenital heart disease. Following groups should be considered at high risk for developmental delay. They include neonates or infants requiring open heart surgery, both cyanotic and acyanotic types, children with other cyanotic heart lesions not requiring open heart surgery in the neonatal or infant period, children with any combination of congenital heart disease and other comorbidities as previously outlined in the table of those with high risk, and other conditions determined at the discretion of the primary care provider. Risk stratification of patients with congenital heart disease into low and high risk categories for developmental delay at every primary care visit can be useful and beneficial. Behavioral screening of patients with congenital heart disease undergoing developmental screening based on age or concerns detected in surveillance can be useful and beneficial as well. For patients with congenital heart disease stratified as being at high risk for developmental delay, the following strategies can be useful and beneficial: referral to formal developmental and medical evaluation, referral to early intervention services or early childhood special education services before confirmation of a specific developmental diagnosis, periodic reevaluations for developmental disorders and delays at 12 to 24 months, 3 to 5 years, and 11 to 12 years of age, referral of young adults for higher education and/or vocational counseling. Specialized neurodevelopmental follow-up clinics for children with complex congenital heart disease have been created at several pediatric cardiac centers throughout the country. These clinics include multidisciplinary teams, which may involve a developmental pediatrician, pediatric psychologist, neurologist, as well as consultation with nutrition, special education, speech and language therapy, physical and occupational therapy. The Cardiac Neurodevelopmental Outcome, or CANDO program at Children's is one of the region's programs designed specifically to monitor neurodevelopmental growth in children born with congenital heart disease. The CANDO team is a multidisciplinary team composed of a cardiologist, child development, neurology, neuropsychology, and they work with patients from infancy through adolescence and teen years to identify and manage any developmental problems. In infants and toddlers, developmental specialists evaluate the child's motor, cognitive, and language development, as well as play, behavior, and feeding skills. Recommendations are provided to the family, as well as the child's cardiologist and pediatrician. A neurologist also conducts a neurological screening and schedules follow-up visits as necessary. Specialty referrals, if needed, for physical, occupational, or speech therapy, as well as nutrition, may be included. School-age children undergo a comprehensive neuropsychological evaluation before starting kindergarten or first grade, and again before middle school and high school. These evaluations assess intellectual skills, attention, executive skills, learning, memory, visual, spatial, motor skills, as well as emotional, behavioral, and social functioning. Detailed treatment recommendations with the goal of promoting development and learning are provided. In addition, documentation that can be helpful in obtaining educational support and interventions is provided if needed. There is an education liaison that can also help parents navigate the process of obtaining resources in school and the community. If a child undergoes heart surgery within the first year of life at Children's, he or she is automatically enrolled in the CANDO program. A pediatric cardiologist or pediatrician can refer the patient to the program at any age. They meet the following criteria. They had a heart surgery in the first year of life, have a cyanotic heart defect, have a heart defect and a neurologic risk factor, such as stroke, seizure, or other neurologic abnormality, even if surgery was not required, or if there is a developmental concern during a routine exam in a child with congenital heart disease, even if surgery was not required. Most patients with congenital heart disease should maintain the recommended immunization schedule. Specific considerations related to heart transplant are beyond the scope of this talk today, and I won't be touching upon that. Standard practice at this time is to immunize on schedule with full-dose vaccines. However, many surgical interventions are now being scheduled in the first year of life, and this is the same period at which time most immunizations are being given. Although it is very important to avoid any barriers to immunization, there may be adequate reason to alter the recommended schedules to optimize immune response. Surgery for congenital heart defect not only requires hospitalization, but also the use of cardiopulmonary bypass and the need for blood component transfusions. Transfusions of certain blood products may have a significant impact on immunomodulatory effects for 4 weeks or more, and may affect the immune response to vaccines. Specific blood products may diminish the body's capacity to mount an active response to live virus vaccines over varying periods of time. Therefore, delaying any immunization until 6 weeks after cardiac surgery to ensure appropriate immune response may be recommended. Illnesses such as RSV and influenza present a major source of morbidity and mortality for children with congenital heart disease. Strategies to prevent these common illnesses are an important part of primary care. Focusing on the education of families regarding hand hygiene and avoiding crowds during the winter months may reduce exposure. The influenza vaccine is recommended for all children older than 6 months. In addition, caregivers and household contacts of infants younger than 6 months should receive the influenza vaccine. All children are at risk for respiratory syncytial virus or RSV during the winter. The use of palivizumab has been shown to reduce RSV-associated hospitalizations in children with CHD. Certain children who are 12 months or younger with hemodynamically significant CHD may benefit from palivizumab prophylaxis. Children with hemodynamically significant CHD who are most likely to benefit from immunoprophylaxis for RSV include infants with cyanotic congenital heart disease, acyanotic heart disease who are receiving medication to control congestive heart failure symptoms and will require cardiac surgical procedures, and infants with moderate to severe pulmonary hypertension. These recommendations apply to qualifying infants in the first year of life who are born within 12 months of onset of the RSV season. The following groups of infants with CHD are not at increased risk of RSV infection and generally should not receive immunoprophylaxis. Infants and children with hemodynamically insignificant heart disease, for example, a secundum atrial septal defect, small ventricular septal defect, pulmonary stenosis, uncomplicated aortic stenosis, mild coarctation of the aorta, and patent ductus arteriosus. Infants with lesions adequately corrected by surgery unless they continue to require medication for congestive heart failure. Infants with mild cardiomyopathy who are not receiving medical therapy for the condition, and children in their second year of life. Children with CHD who qualify should be offered the vaccine starting in early fall and each month for 5 months during their first year of life. Clinicians may administer up to a maximum of 5 monthly doses of palivizumab, 15 milligrams per kilo per dose, during the RSV season to infants who qualify for prophylaxis in the first year of life. For qualifying infants who require 5 doses, a dose beginning in November and continuation for a total of 5 monthly doses will provide protection for most infants through April and is recommended for most areas of the United States. Because a mean decrease in palivizumab serum concentration of close to 60% was observed after surgical procedures that involve cardiopulmonary bypass, for children who are receiving prophylaxis and who continue to require prophylaxis after a cardiac surgical procedure, a postoperative dose of palivizumab should be considered after cardiac bypass or at the conclusion of extracorporeal membrane oxygenation for infants and children younger than 24 months. Certain children with congenital heart disease are at greater risk for morbidity and mortality associated with infective endocarditis. The American Heart Association recommends maintaining oral health and hygiene with regular brushing, flossing, and visits to the dentist starting at age 1 year to reduce the incidence of bacteremia from daily activities. Administration of prophylactic antibiotics prior to dental procedure is indicated for patients with highest risk of adverse outcome resulting from endocarditis. Children at high risk include those with artificial heart valves, a previous history of infective endocarditis, and certain types of congenital heart disease. This category includes children with unrepaired cyanotic congenital heart defects, including those with palliative shunts and conduits, those with completely repaired defects with prosthetic materials or devices for 6 months after the procedure, whether placed by surgery or transcatheter intervention, as well as repaired congenital heart disease with residual shunts and or valvular regurgitation at the site or adjacent to the site of a prosthetic patch or prosthetic device, which inhibit endothelialization. Administration of a single dose of antibiotics 30 to 60 minutes prior to dental procedure is recommended. The typical dose is 50 milligrams per kilo of amoxicillin orally for children. Guidelines also include information for those unable to take oral medications, as well as those with allergies to penicillins or ampicillin. Caregivers should be reminded to inform dentists and dental hygienists of their cardiac condition prior to any dental procedures or cleaning. Asplenia, both functional and anatomical, can occur in conjunction with complex congenital heart disease, particularly in patients with heterotaxy syndrome, and there are special immunologic considerations for these patients. Heterotaxy syndrome is characterized by an abnormal distribution of the major visceral organs within the chest and abdomen. In patients with heterotaxy syndrome, in addition to complex congenital heart disease, there is often absence of the spleen or many small, non-functional spleens, known as polysplenia. Therefore, children with asplenia or polysplenia are at increased risk for infection. The risk for infants younger than 6 months of age is primarily infections caused by Klebsiella or Escherichia E. coli. After 6 months of age, the risk is greater for infections caused by Neisseria meningitidis, Streptococcus pneumoniae. Therefore, children with asplenia should take prophylactic antibiotics and receive all their scheduled immunizations. The AAP report from the Committee on Infectious Disease recommendations include continuous antibiotic prophylaxis in infants, children, and adults with asplenia syndrome. The usual regimen is 125 milligrams of oral penicillin B twice a day for children younger than 3 years of age, and 250 milligrams of oral penicillin B twice a day, or 20 milligrams per kilo per day of amoxicillin for those over 5 years. Parents should be aware that all febrile illnesses can be potentially serious, and immediate medical attention should be sought. These children are significantly at higher risk for fulminant bacteria, most often with Streptococcus pneumoniae, associated with a higher mortality. These children should have blood cultures and be treated with antibiotics to cover Streptococcus pneumoniae, H. flu, Neisseria meningitis until the specific organism is identified. The age at which antibiotic prophylaxis should be stopped is controversial. The AAP recommends that antimicrobial prophylaxis can be discontinued at 5 years of age, provided the child has not had a pneumococcal infection and has received the recommended dose of pneumococcal immunizations. Certain cardiac centers may recommend continued prophylaxis in asplenia patients with congenital heart disease to be continued after age 5. Patients with asplenia and congenital heart disease should receive pneumococcal vaccines in infancy and after 2 years of age per the most current CDC guidelines. The current CDC recommendations for prevention of pneumococcal disease recommend that all children with congenital asplenia receive a complete series of doses of PCV13. Given increased risk for invasive pneumococcal disease because of anatomic or functional asplenia, children aged greater than or equal to 2 years should receive PPSV23 after completing all recommended doses of PCV13. They should receive the first dose at least 8 weeks after any prior PCV13 dose, then the second dose of PPSV23 at least 5 years after the first. In addition, the CDC recommends, due to an increased risk for meningococcal diseases due to asplenia, infants aged 2 through 23 months receive vaccination with an age and formulation appropriate meningococcal conjugate vaccine. Infants are recommended to receive a 4-dose vaccination series with doses at ages 2, 4, and 12 months. Per the CDC, children with functional or anatomic asplenia should not receive Menatra before the age of 2 years. This timing avoids interference with the immunologic response to the infant series of the pneumococcal conjugate vaccine PCV13. The CDC recommends infants 2 through 23 months of age with functional or anatomic asplenia receive Menveo, which does not demonstrate immune interference and can be administered concomitantly with PCV13. Patients with DiGeorge syndrome or 22q11 chromosomal deletion, in addition to conotruncal cardiac heart defects, can also have an absent or hypoplastic thymus. The effect of DiGeorge syndrome on cell-mediated immune response are related to thymic hypoplasia, and the response is widely variable from no decrease in T cells to severely low or absent T cells, with resultant decrease in immunity. This can affect the incidence and severity of infections, prevent the use of live virus vaccines, as well as alter the immune response to other vaccinations. In children with DiGeorge syndrome, an immunology consultation and additional lymphocyte studies should be obtained before live virus vaccines are administered. The decision when to give these live virus vaccines should be made in consultation with an immunologist. Routine physical activity and exercise in patients with congenital heart disease are associated with better quality of life, improved cardiorespiratory and musculoskeletal fitness, and improved motor skills in children. Routine physical activity reduces the risk of chronic conditions of obesity and cardiovascular disease. The American Heart Association recommends a combination of moderate and vigorous physical activity for both children and adults because of the potential long-term physical benefits of decreasing one's risk of developing coronary artery disease, hypertension, stroke, and obesity. At this time, the AHA recommends children and adolescents participate in at least 60 minutes of moderate to vigorous physical activity every day. Most patients with congenital heart disease can participate in daily physical activity and recreational sports. The management approach to physical activity in congenital heart disease consists of assessment and goal setting, exercise prescription and counseling, and follow-up of activity and readjustment of goals as necessary. Goals are often developed based on the following physical activity assessment. Physical activity assessment may include obtaining history of the underlying cardiac defect, evaluation for exertional symptoms, such as dyspnea, chest pain, or syncope with exertion, assessment of cardiac condition, including evidence of ventricular dysfunction and arrhythmias that may limit the intensity of activity, evaluation of the patient's current level of activity, as well as a cardiorespiratory assessment, including echocardiographic evaluation of ventricular function, electrocardiogram, and in patients with a cyanotic heart disease, pulse oximetry measurement of oxygen saturation. In some cases, exercise testing is used to assess risk and functional exercise capacity of the patient in a controlled setting and may be helpful in counseling and reassuring patients and their families. Recommendations include a prescribed routine physical activity regimen that is provided to all patients with congenital heart disease. For patients with successful repair and no residual sequelae, the physical activity goals are generally the same as those of the general population. This entails 60 minutes per day of physical activity for children between 6 to 17 years of age and 150 minutes per week for adults. Although the vast majority of patients with congenital heart disease can participate in daily physical activity and recreational sports with minimal risk, there are certain settings in which unrestricted intensity of physical activity may be detrimental to the patient. These include patients with significant ventricular dysfunction. Those with significant ventricular dysfunction may be at risk for developing ventricular arrhythmia if they participate in intense exercise and competitive sports. However, these patients can still participate in a wide range of daily physical activity and recreational sports. Those with severe left or right ventricular outflow tract obstruction, patients with significant pulmonary hypertension, with RV pressure approaching or exceeding systemic pressures, or with RV dysfunction or symptoms of pulmonary hypertension, in patients with dilation of the aorta. A severe dilation of the aorta can be associated with an increased risk for aortic dissection. Exertion can increase blood pressure and therefore increase the wall stress of the aorta, which may in turn increase the risk of aortic dissection in certain patients. Patients with certain arrhythmias, including long QT syndrome and other congenital channelopathies resulting in arrhythmia. In patients with hypoxia, physical exertion may increase cyanosis in selected patients, particularly those with elevated pulmonary vascular resistance and intracardiac shunting. However, hypoxia does not need to be a reason for elimination of daily physical activity. Rather, physical activity can be adjusted to a comfortable level for the patient. A 6-minute walk test with monitoring of the oxygen saturations may be considered in order to guide assessment and guide recommendation for physical activity in these patients with cyanosis or hypoxia. In patients with congenital heart disease and exertional syncope, further investigation is needed to determine and manage the underlying cause, such as possible arrhythmia. Patients that are at risk for syncope during activity should avoid activity that would endanger themselves or others should a syncopal event occur while involved in the activity. For example, horseback riding, scuba diving, rock climbing, and gymnastics. Other activities such as swimming, ice skating, bike riding can be considered if done with supervision. Certain coronary artery abnormalities, such as anomalous origin of the coronary artery or cases of coronary artery compression or insufficiency, may lead to increased risk of sudden cardiac death with activity, and restrictions will be dependent on the specific patient. For patients with pacemakers or implanted cardiac defibrillators or ICD, the main goal is protection of the device and leads and prevention of any soft tissue injury due to impact to the device, and this should be considered when considering sports, particularly contact sports, that may have a high likelihood for direct blows to the device and injury to the chest, such as boxing, tackle football, ice hockey, and martial arts. These should be avoided to prevent damage to the device and soft tissue injury to the patient. Generally, appropriate shocks from ICDs successfully terminate arrhythmias during exercise, and this is not typically a concern in these patients. Patients who are taking anticoagulation medications should avoid high-contact sports in which body impact is an intentional aspect and may cause injury, as well as sports which could potentially involve high-speed impact, such as downhill skiing, in order to avoid bruising or bleeding, and specifically head injury. For sports with unintentional contact, factors that are important to consider before approving participation include bleeding history, current medication and level of anticoagulation, patient skill, and specific activity. Special considerations for patients with congenital heart disease may be required for participation in competitive sports because competitive sports fundamentally differ from recreational exercise and routine daily physical activity. Participating in training for competitive sports typically involves high-intensity levels of activity, which are imposed by the coach or the playing conditions. Individuals playing competitive sports have less ability to self-regulate their effort and may not be able to take breaks or decrease effort intensity in response to their cardiac symptoms. Scientific statement of the American Heart Association and American College of Cardiology provides competitive athletic participation guidelines for patients with congenital heart disease. They utilize a classification of sports based on increasing static and dynamic components. The patient's cardiologist will often tailor recommendations for physical activity and sports participation based on the guidelines and a comprehensive evaluation. If there are any specific questions or concerns regarding participation in a specific activity, the child's cardiologist can be contacted. There are certain symptoms during exercise in patients with congenital heart disease that may indicate further cardiac evaluation is necessary prior to participation in sports. Some of these red flag symptoms during exercise include syncope, chest pain, palpitations, dizziness, dyspnea, and significant changes in activity tolerance. If patients or parents report any of these symptoms with activity, the patient should be referred back to their cardiologist for further evaluation prior to participation in physical activity. In summary, there are an increasing number of children with congenital heart disease surviving to adulthood because of improving diagnostics, medical management, and surgical interventions. Children with congenital heart disease can have unique issues related to health maintenance as a result of their underlying heart disease. The primary care provider plays a critical role in the long-term health and wellness in patients with congenital heart disease. Therefore, ongoing communication between the patient's primary care provider and primary cardiologist is an important factor in their well-being. Focused attention in certain areas, such as growth and development, nutrition, immunizations, dental care, and physical activity should be included in primary care visits. Thank you for your time today, and I would be happy to take any questions.